appreciate your patience and sticking with us today. Our next one is also a very important topic. As we have discussed, we've been working on infections, talking about antibiotic stewardship and all the components that go into that process in terms of how we deliver and avoid those reportable hack events, etc. So again, today we're going to get a chance to hear from another of our hospitals. This will be Monroe County Hospital, sharing with us what is going on in their institution about how to measure success with your antibiotic stewardship program and some of the best practices from their facility. Dr. Matthews is going to be speaking along with Dr. Martens. They will both take questions immediately after their presentation, so we'll give you a chance to do that. We appreciate the continued partnership we have with BD MedMined. They've been with us since the very start back in 2006, and we've had a great partnership, and we thank you all again for that. Today, Felicia Matthews is going to talk about how to measure success with your Antimicrobial Stewardship program. She's a senior consultant in BD MedMined Services. Prior to work at MedMined, she spent a number of years with the Veterans Administration hospitals and most recently as Associate Chief for Clinical Pharmacy Services at the VA Medical Center in Tuscaloosa. Flip my page here real quickly. She received her doctorate in pharmacy from Auburn University and did a residency in geriatric pharmacy with the VA Medical Center and Duke University. After she finishes speaking, then I'm going to let Cynthia Martens come also. On a recent site visit, ALHA staff met with their facility, had a chance to see some of the things that they were doing related to medications and patient safety. She is the pharmacy director there and most recently served as the interim CEO of the hospital, and she will come and share her work there. She has 31 years of experience providing pharmacy services in retail, hospital, and outpatient home infusion settings. She received her doctorate in pharmacy from Auburn University and has been a leader in the field, helping to establish the Alabama Independent Drugstore Owners Association along with 3 other independent pharmacies in 1994. She has been a leader with the Alabama Pharmacy Association and was presented as President's Award in 2008. So I appreciate both of these coming forward. So Dr. Matthews is first.
Okay, so usually my voice is very robust for this program, and I have an 8-month-old now, and I get all his germs. So please let me know if you can't hear me, if I need to do something different. So today we're going to talk about how to measure success with your antimicrobial stewardship program. And I did something wrong. Here are my disclosures. So today we're going to review antimicrobial resistance and the regulations that pertain to it. We're going to look at actions that you can use to build a strong clinical program, and then review our statewide antibiogram as well as the utilization and see how we can put these actions into place in order to build a strong clinical initiative within your hospital system. I'm not picking up here. Just go right here. So let's talk about the numbers. We know that 30 to 50% of all antimicrobials that are given in an acute care hospital setting are considered to be unnecessary. The things that we're most concerned about are going to be those broad spectrum antibiotics. In 2017, the CDC did some research and they found that there was a 37% increase in our carbapenems. In addition, a 32% increase in our vancomycin. Now that's kind of concerning to me because all the numbers that's been coming out from the CDC and that we've been reporting is that MRSA is at an all-time low. We know that it's at an all-time low because we've had great infection control that has been swabbing those patients as they come into the hospital, as they have those transfers, and we have seen the numbers go down so far that those initiatives are being replaced and you don't even have to swab every patient now. There are definitely hospitals that are moving away from that. So why is our vancomycin use going up? With our pediatric patients, we've done much better. We have a decrease in that for about 8.5%, but in our adults, we've almost seen a 10% increase in how we're utilizing antibiotics. And all of that utilization is leading to the numbers of 2 million. There are 2 million antibiotic-resistant bacteria infections that we see every year. And of those, the most prevalent from that CDC threat report that came out is still C. diff. So C. diff has actually increased. So since that report came out in 2014, it's gone from 250,000 illnesses a year to 500,000 illnesses a year. It accounts for 15,000 of the 23,000 deaths that we see every year with an antibiotic-resistant bacteria. And most common of that is going to be in our elderly population. 80% of those deaths are going to be in our patients that are greater than 65 years of age. So in light of all that, CMS, Joint Commission, and CDC all said, what can we do to help? How can we help hospitals look at their program and figure out what they can do to help with stewardship of our antimicrobial use? So for CMS, they came out and they changed their conditions of participation for infection control, moving it to infection prevention, which is what most people had already started doing anyway. Stop looking at the numbers and start preventing infections from occurring. Once this occurred, there was a ruling, 3294P, that came out saying you got to have the change to prevention, and then we also want you to put antimicrobial stewardship programs all throughout the hospital and make sure that they're different in different areas, because your ICU is going to be different from your medical floors. That ruling still hasn't been finalized yet, although many hospitals have started putting into place those regulations that are there. APIC as well as SHE has put a letter out to the Medicaid and Medicare Secretary to ask that they go ahead and finalize that rule. It actually expires this year. So all the things that were put into place, all the funding that's been put behind it, that could expire within your hospital if they don't go ahead and sign that ruling. And that letter was sent to them in November, urging them to let us continue to make efforts and move forward in our antimicrobial stewardship efforts. For the CDC, they have 3 different areas that they're looking at, but today we're most concerned about what we can do inside of our facilities, but they have their core elements in outpatient long-term care as well as acute care hospital. The acute care hospital is so closely aligned to Joint Commission. I'm just going to focus on Joint Commission because most hospitals, that's where we have our regulatory looking at us. That came out 2016, that they actually start measuring that for their medication management standards, MM090101. And with that, there are 2 different parts of how I want to break it out. So the first 3 is what the hospital has to do for you to make sure that you have a successful stewardship program. They have to, for leadership commitment, provide you with finances as well as technology to make sure that you have a successful stewardship program. They have to provide you with a physician leader. Does not have to be an infectious disease doctor, but they do have to provide you with a physician leader who is tasked with making sure that that program is successful. And they also have to provide you with a pharmacist to help look at the utilization in your hospital system. All 3 of those things is what the hospital needs to do for you. For the 3 they give you, they ask you for 4. So they want to make sure that you put an action into place, a change in a policy or procedure, something that we can measure. That's when you're tracking part. So you want to make sure that you are able to track that utilization as well as an outcome from that change in policy and procedure. You're going to make sure that you report that information back, if not to your Antimicrobial Stewardship Committee alone, but also to your P&T and your MedExec programs. And then educate all hospital staff, not just have your doctors and your nurses know what's going on, but the entire hospital staff, because antimicrobial stewardship is a group. It's a group of people that work together to make sure that it happens. So we're like, yes, okay, we're ready. You're going to give us a whole bunch of details on this action. And the only thing they gave us was, let's do a 48-hour timeout. That was their recommendation. And everybody put it into place. But then what did you do with it? Does everybody get cultures back in 48 hours? Is everybody stable in 48 hours? 48 hours was meant to catch those 30 to 50% of the people that didn't need it. But after you go through that and you're laboriously looking through everybody that's been on it that amount of time and you have to document no changes right now, what do we do next? So I think there are actions that can be built around 3 different areas: your utilization, your resistance, and antimicrobial choice. So for your utilization, What antimicrobials are used the most in your facility? Do you know whether or not the antimicrobials that are being used actually increase the risk of C. diff in your patient? Do you know which units in your hospital have the highest utilization? Does your facility produce an annual antibiogram that you get at the beginning of the year? Because at my old hospital, we shared a pathologist, so although it was produced in January, it was not released until July. What are the resistance patterns within your facility? And do you know if they're changing, for better or for worse, by 5% from year to year? Are empiric choices made in your facility based off of your annual biogram? Were cultures and sensitivity obtained prior to the first dose of antibiotics being given? Was therapy reevaluated based on the cultures that were received? And was the patient reviewed for opportunities to change route and/or duration? So when we look at this a little bit more, you need to make sure that you know your baseline data for your days of therapy adjusted by 1,000 patient days or days at risk, so that you know exactly how things are being utilized in your hospital, and that's irrespective of what month it is. So that's why you want to adjust that risk, because we know it's going to spike during our flu season. But how does that utilization look? Are you reviewing the quinolones and broad-spectrum antibiotics within your system? Because it is not just fluoroquinolones that increase the risk of C. diff. How is your H-trianan being used in your facility? How are those third and fourth generation cephalosporins being used? How are you using your Recefin? And then start reviewing areas in your facility that have the highest utilization. Sicker patients are going to need more antibiotics. It doesn't mean that they need broader antibiotics. It just means that they may need more therapy than if they're on a regular medicine floor. So your ICU may be using more medication, but what they're using actually appropriate? Review your annual antibiogram. If you are not aware of changes in resistance within your hospital system, it is impossible for your physicians to go out and make a determination in your EDs about what's going on when they're coming in. They do not have any cultures that are there. This is most important for them because they're going to be seeing things or eyeballing things. They're the ones that's having to make that split second decision. And if they do not know what the resistance patterns are inside of your facility, they have no idea if they're continually to prescribe medication that is increasing resistance or is not even going to hit the patient. And then make sure that you educate the hospital staff. Empiric therapy must be based on evidence-based guidelines, but tempered by your resistance patterns. It does not make any change if IDSA says you must use antibiotic A, and antibiotic A has a susceptibility of 50% in your facility. You must not use that. That is not going to help your patient. That is not going to help your patient unless you have a culture to know that it is actually going to work in that patient, because in your facility, you do not have that susceptibility. And we know that susceptibilities change when they move from one state to the next and from different regions. Once you get your cultures, you must consider narrowing your therapy. We're always going to start big, right? Go big or go home. We're going to start big. We're going to give them Vanc, we're going to give them Zosyn, and we're going to send them up to the floor. But once you get those cultures back, we are not going to be able to, anytime in the future, have they seen there being any benefit of doing genetic testing because it's so costly. The closest thing we have to that is getting those cultures and sensitivity back, seeing actually what's going to work for your patient. Your labs have algorithms that they're running in the background. If for some reason something's sensitive today, but 2 days later is going to be resistant, they are not going to put that out for you to see. That will be suppressed. So you can trust those results that are coming back on your culture and sensitivity. And then of course there's clinical judgment that has to be used to make sure that where that infection is, that antibiotic is actually going to reach inside of that tissue to make sure that it's effective. And when the patient improves, let's consider moving them from IV to PO. We definitely know that our fluoroquinolones, azithromycin, metronidazole, All of those types of antibiotics have the 1-to-1 change ratio from an IV to PO. They all have very good bioavailability, and we can use those and change those patients because once we get them off of IV to PO, we get ready to start about taking them home. And the longer they stay within your facility, the more at risk they are for getting a hospital-acquired infection. The longer they have a line in to give IV, the longer you're at risk for getting a eclampsia. So let's make sure that we are considering those changes. And make sure the patient remains on therapy only as long as they need to. So we put them on vancomycin when they come in the door. 2 days, 3 days later, you get a culture back and you want to change them. Well, if they came in for a UTI and they're a woman, that 3rd day, you can pretty much discontinue them. At most, they shouldn't be on it for additional 2 more days. Just because you change the antibiotic does not mean that you start the clock over on your time, because we'll change them from IV to PO, we'll leave them on there until they discharge from the hospital and give them 7 days when they get home. And then they come back to the facility. So we have to make sure that unless the culture comes back and says that the antibiotic they were on is resistant, that we continue to count those days when they first came in the hospital and make sure that we are tailoring our duration of therapy in that manner. So this year I want to do something a little different, and I want to take those bugs that are important for our hospital system, so those nasty space bugs, and I want to look at them and compare them to the utilization that we have statewide through Alabama, and then use some of these actions that we've talked about to see how we can build a good antimicrobial initiative inside of your facility using some of this data. So you guys should have gotten an antibiogram when you came in the door. If you didn't get one, please see us. We can make sure that you have one available before you leave. But we took isolates from 56 hospitals in Alabama for the entire year of 2018. We did 1 isolate per 365 days, and duplicates were removed. And anything that was significantly different in the susceptibility was considered to be a unique result. For this presentation, community would be collected outpatient or within the first 3 days of that admission, and they had no admissions within the past 14 days. For hospital, those that were collected inpatient on or after day 3, or they had a readmission within 14 days of being discharged. So when we look at our statewide utilization, we look just like the rest of the country and other teaching and non-teaching facilities. So Alabama's not utilizing more antibiotics overall than any other hospital across the country. So when we take a look at our enterococcus, this is going to be enterococcus in the hospital, so non-urine. Everything I'm going to talk to you about today is going to be in the blood. We can see that we've had a steady decrease in those isolates since 2012. But what we're most concerned about is our Enterococcus faecium, because that tends to be the one that's more resistant. When I think about Euphocalis, you can treat it with a list of things. But Enterococcus faecium tends to be a little bit more resistant. And when we talk about resistance, the main things that we would want to think about treating that with would be our vancomycin. So this is our VRE, and it's going to have a 77% resistance to the Enterococcus. And it hasn't changed very much this year from what our resistant isolates were. Last year it was about 33%, this year was 30%, but had a few less isolates, so about the same, unchanged. The good thing about it is that linezolid is only 4% resistant, so we still have 96% susceptibility to it, and unless your patient's on an SRI, you should be able to treat them with linezolid, and I always say monitor them because I always saw a lot of thrombocytopenia with the drugs, so just some things that you have to monitor with them. Other things we could use to treat would be daptomycin. So when I look at our daptomycin utilization, we're above what is in our region. So all the other southeastern states that are around us, we tend to be prescribing a little bit more, but we're not as much as other teaching nationally facilities that we see. The thing that I would temper with this is that when we look at the CDC and how they rate resistance, for us, daptomycin resistance to Enterococcus faecium is at 23.2%. So with linezolid only being at 4% resistance, we really have to monitor and make sure that we're not using that daptomycin as the go-to every time we see a slight bump in their renal function when they're on the drug. Remember that vancomycin can be dosed for the patient. We can also do that with linezolid. We also have new drugs that we can treat this with. So we have some of those one-time doses of things that we can use that we talked about last year. So just making sure that we're careful that when we're using daptomycin, we're using it because they were resistant to vanc and linezolid, and not just because there was a slight bump in the renal function that we might be able to monitor more closely, get some random troughs if it's not vancomycin resistant, able to do that, or maybe adjust that dose of linezolid. So again, MRSA, all-time low, relatively flat, only 58%. We know that typically our utilization looks different than across the country. I like to say California's lower, but our chicken is better, so we have a little bit more diabetes down here. That's gonna make us have a little bit more MRSA, but it's at an all-time low. And the really good thing about that is that there still is no resistance. There's no resistance to vancomycin when you're treating MRSA. If your patient has MRSA and their renal function is not bad, and when I say not bad, we know we can dose vancomycin in our dialysis patients. So if they have a stable renal function that you feel, that the providers feel comfortable that they're not causing harm, we should be using vancomycin for MRSA. We know that there's been a little bit of separation over the past couple of years with our community versus hospital acquired, with this increasing in the hospital acquired. It could be a little bit more than this, just because in community here, we're gonna put some of those long-term care in there, and typically we wouldn't think of long-term care as being considered to be those patients that are not hospital acquired. We wouldn't really consider that community. So when we look at our utilization of linezolid, it does tend to be higher nationally than other teaching and non-teaching facilities. So again, like I said, for MRSA, there is no resistance to vancomycin. We should be using vancomycin because there is actually nationally resistance to linezolid to MRSA. And Alabama tends to be higher than the national resistance that CDC has seen over time. So when we look at these kind of things, what can we do? What kind of actions can we put into place? There are things that we can do as far as, are there directive order sets within your system, within your EHR? So can you have a decision tree that says, if the patient, does the patient have MRSA, yes or no? Is it resistant to vancomycin? No. Don't even let them get to the dapto. Direct them towards the vancomycin. We can also run reports. We can get targeted notifications. Tell me any patient that's on daptomycin or linezolid and it's sensitive to vancomycin. We can run lists. Let me know anybody that's on that daptomycin or linezolid and they have MRSA. These are different initiatives, different things that we can put in place so that you can build a clinical initiative around that. You can measure that, and then you can report that outcome. So when Joint Commission comes, you can tell them exactly what you did. So now I'm going to move over into our gram-negative. And for this one slide, instead of talking about resistance, I'm going to talk about susceptibility. Last year I was very sad. I was very serious when we came up here and I talked about how bad our susceptibility was to Acinetobacter. And I feel like you all went back and told the hospitals exactly what had to be done, because it has changed around quite the opposite this year. So we actually have increased our susceptibility up to 76%. Now we did have a decrease in the amount of isolates that we actually tested for this particular organism, but the susceptibility looks really good. This is always going to be a hard to treat infection. You're always gonna have to use 2 drugs to treat it. And we know that more than likely it's gonna have to be a carbapenem that we're gonna use as the backbone of that therapy. So we don't wanna be using the carbapenem in other areas when we know we need to save it for things like Acinetobacter. So when we look at our utilization, it started to trend down. We're less than all the teaching hospitals across the country, but we're right along with everybody that's in our region. So that's pretty good. When we look at it nationally, we have also seen the resistance and the intermediate, how carbapenems are to Acinetobacter, go down. So nationally, they're at 52.7%. And we're somewhere around 24% now. Because again, I said we had a 76% susceptibility of our carbapenems to Acinetobacter. So we're back doing a good job again. So when we talk about Pseudomonas, I'm going to break it up into several different antimicrobial classes. So talk about our beta-lactams and our monolactams. We've actually seen a pretty good increase in our susceptibility for piptazo and cefepime. They continue to trend up, which is good. But when we look at H-trianam, it's been kind of flat, and it had a pretty deep dive down to 60%. H-trianam should really be used for our patients that are allergic to penicillins. And not the penicillin runs me to the bathroom, but I get hives, I'm anaphylactic. That's really where that use should be. Even though it's an antibiotic that only treats gram-negative, it is still very broad spectrum. And if your patient actually does have a penicillin allergy, you can't empirically treat them with Pseudomonas at a 60. So this would be one of those things that when we talk about our utilization, we've seen that it's actually started to trend down. So we are lower than other facilities regionally and nationally, but regionally there is a lot of use of H-trianam. This would definitely be one that I would want to report on. I would want a targeted notification letting me know when a patient is on this antibiotic so that I can look to see if there's something else that they could be on, if there's cultures and sensitivities that come back. Piperacillin's our workhorse. It's always going to be our workhorse, but we are currently prescribing this medication greater than other teaching and non-teaching facilities, not only nationally, but again, regionally. What we want to do is make sure we know we have to hit them hard when they come in the facility. We do not want to wait. We cannot put them on an antibiotic that doesn't cover everything when you are not sure what's going on. This is definitely one of those times that you want to use your cultures and you want to de-escalate when possible. We need piptazo. We need to make sure that we are preserving its utilization. And I think it was 85% is what we have. We need to make sure that that not only stays, but continues to increase. And the only way that's gonna happen is if we become good stewards of this medication and we don't restrict drugs, we preserve drugs. So make sure when you're talking about this to your providers, when you're talking about this, we don't talk about it in negative terms because we don't want to take things from our physicians to be able to treat their patients. They need every tool available to treat, and you want to preserve every tool that they have so that they're able to treat their patients. When we look at piptazo resistance, we are higher nationally from what the CDC has. So there's definitely work that we can do to make sure that this drug is being used appropriately. For our carbapenems, we've seen a very nice increase. I think that the imipenem kind of stays where it is because we've gotten away from using imipenem so much. So being able to see that there's an increase in the meropenem is really good. Even over the past 3 years, we've seen that go up. And we're almost at 80% for that. So we definitely want to make sure that we keep doing a good job with how we're using our carbapenems. Again, we saw that our utilization was below other teaching hospitals nationally, and continue to make sure that you have those programs out targeting those particular antibiotics so that you can make sure that they're being used appropriately. Our fluoroquinolones, we use them so much because they're oral and they're IV and they're 1-to-1 and they have the great bioavailability and they treat everything, right? So we're saying, hey, they got something, give them a fluoroquinolone. We have to make sure that we continue to target these drugs. I feel like there's been a lot of work done with them, and on top of the black box warnings that's come out with the tendon ruptures and things of that nature, providers really have gone away from just really going to one so much, having that be their only trick in their bag to make sure that they're treating something appropriately. We have seen that since 2013, there's been a steady increase in our susceptibility to this class of drugs. And there's actually been a 29% reduction in utilization over the past 2 years. So the efforts with fluoroquinolones, with there being the black box warnings, with there being the increased risk of C. diff, we've done a really good job. That's almost everybody's initiative when I talk to my different hospitals. Well, we target our fluoroquinolones. So we just have to make sure that we continue to do that and continue to do a good job of it. When we look at it, we're definitely not in the highest rate of resistance, but Alabama tends to be a little bit higher than nationally. It's just a little bit. So I would say that we're probably right there in line with them. It's a 1% difference. So I wouldn't say that that's terribly bad, but we just want to make sure, even though we've made good efforts, we've seen the utilization go down by 29%, we still have more room that we can grow. So we don't want to let up on this initiative. Third and fourth generation cephalosporins, everybody gets Rocephin. I sound like this, I haven't gone to the doctor, but if I went, they'd say, do you want a shot? And I would say, no, it hasn't been 10 days yet, I'm still watchful waiting. But it tends to be what we go to. And I can go to hospitals and they can get cultures and sensitivities and they go, oh, but they're on Rocephin, I don't need to de-escalate. Why? They can be on cefazolin. They have a UTI, everything collects in the urine. Go ahead and change them. Just because they're on Rocephin doesn't mean that we can't go smaller. That's our third generation. Let's go to a second. Let's go to a first. We can continue to de-escalate. That's something that we should do. I think the third generation cephalosporins are our low-hanging fruit inside of our hospital. And if you were to actually look at it, as you can see how that utilization is higher. We've gotten so comfortable saying let's go to it and focusing on those broad spectrum that we see all of those going down and we see there being a ton of utilization here. And if we were talking about treating a UTI within a hospital, I'll tell you on your antibiogram, utilization to, I know for our fluoroquinolones, utilization to E. coli is at 55%. We've got to watch how we're treating because those common bugs, we're losing utilization for them. Proton pump inhibitors. There has been lengthy conversation about proton pump inhibitors and how they contribute to C. diff. And there are many things that contribute to C. diff, and it's not just our antibiotic utilization. Although we know that that is one of them, risk factors happen to be our elderly patients, what facilities they're in. There's many things that we can do to work together. But for our PPIs, we need them for stress prophylaxis inside of our hospitals. There is no doubt, there is data to show that they are beneficial and have a place. When your patient gets ready to be discharged, if they do not have GERD on their problem list, please do not send them home on a PPI. Encourage your patients to know that if they have a little upset stomach when they are at home, to take a Tums. Do not go and don't go get the proton pump inhibitor because it's over the counter and you go, but this is the same thing my doctor had and now it's over the counter, I'm gonna use it. They are not benign, just like aspirin is not benign. We have to make sure that if the patient doesn't have an indication to be on that medication, that if we used it for prophylaxis, we then take it off of them before they go home. Because it's not so much the patients that need to be on it because they have some type of GI disorder that's going on, but it's our patients that don't need to be on it that we're seeing that creep up and that additional increase of C. diff. So for our gram-negative, susceptibility to meropenem has improved. We are doing really good with how we're doing that. We still need to make sure that we're monitoring our carbapenem target to get that 80% susceptibility. Assessing patients for opportunity to de-escalate with cultures and sensitivity are going to be the best thing that you can do as far as an action that you put place for this particular organism. And when you are considering looking at our Pseudomonas, use only H-Trianan when there's a true penicillin allergy. Piptazo still remains to be a good choice, but we are overutilizing that in Alabama, and we have seen that resistance be higher than nationally what the CDC is actually putting out. Our meropenem's improved, but again, target is still going to be 80%. And although we have done really well in our fluoroquinolones, our resistance levels still remain above that of what the CDC has. So we still have that area for improvement that we can use. So I thank you for your time and attention, and we'll take any questions if you have them at this time. Yes, ma'am. Wait.
I have a daughter who's also a nurse, and the facility that she works at before, she told me recently that they're going to, where we do acute 6 hours, that they do Q 4 hours. They let it hang for 4 hours, a larger dose. Is that something that you've heard of before?
So what they're trying to do is target a higher MRC or MIC at a faster time. And then if you can do that, you can kind of bring that infection down more quickly so that you're only using it for a shorter period of time. So larger doses for a shorter period of time. And then sometimes you can also do continuous therapy so that you never get that lag. Because, you know, our antibiotics do this and then we redose them and then they come back up and do this. And sometimes they'll do continuous therapy so that it hits this way so that you can use it for a shorter period of time. So I do think those things help. Thank you.
Okay, now y'all can be dismissed. That was great. I really got kind of tricked into this one afternoon. Margaret, Rosemary, and Dr. Tremaine came by, and it was like 4:30, and I was super exhausted. And they're like, well, what do you do? And so I started telling them, and Dr. Tremaine said, well, how many hours in a day do you have, Cynthia? And I said, I don't know. It takes a lot, though. And so they called me back and said, can you put all that together? And I thought, no, I don't really want to do that. I don't have time. But I did. I hope it can help you. It's just something I do at the hospital because there's basically me, and I have a part-time pharmacist that helps. But the key to us being able to do all this in the pharmacy is that I have some great technicians, and I've kind of strategized them to their, kind of looked for their strengths and put them at job tasks, and it's really, really helped me an awful lot. So, which one do you manage? This one. Oh, pointed at that thing? I'm not doing the right thing. See, I can't even operate this. I need my tag. Okay. So I'm in a rural hospital in Monroe County, which is in southwest Alabama. We're like right 100 miles north of Mobile and 100 miles south of Montgomery. And we're licensed for 95, but we probably can put about 45 butts in the bed. But we have a huge outpatient. Our ER sees about 1,400 patients a month. We do labor and delivery there. We have an oncology infusion center as well as an oncology clinic. So we do a lot there. So I have a lot of hats to wear. So I had to figure out how can I put all this together and take care of my patients. And we had a great speaker about putting safety first, and that's really, really important. So I thought I would, these are just things y'all can look at. So there I am, I'm trying to run from everybody, and then they catch me and ask me to be the interim CEO. So I said, okay. I don't know why. I probably don't take Prozac or something, but so I broke it down into these particular categories because I could hit everything with this. Medication reconciliation, I would get so frustrated every morning because we're not a 24-hour pharmacy, we're a 10-hour pharmacy for the pharmacist being on staff there. So I thought, okay, I can't commit to seeing everybody for their med rec. So I came up with a thing where I could just send my technician in, let them go over the medication list, get the pharmacy that the patient uses or the skilled nursing facility. So we came up with, go check it out really good, make sure everything is correct, then I'll look at it and go over it, and I'll try to go through each medication, and if the patient wants to talk to me prior to a discharge, I will go over and talk to them for that as well. But at that point, because, and it's really bad, and I hate to admit this, we use history. They'll pull that med rec from the history, and that's just not good. So I'm trying to figure out a way I can kind of stop pulling the med rec from history, because it includes everything from the first time we ever used that electronic medical record, and it's just not, it's not safe. So that's one of my goals, is to got to start a new one every time they come in. And then, of course, the antibiotic stewardship team, and I've always loved, talking about helping the doctors dose antibiotics, choosing the correct antibiotic, moving them over to orals. Our length of stay is pretty short, so by the time we get the culture and sensitivity back, the patient's going home. They've been on antibiotic, IV therapy probably the whole time they're there. So, but the ones that do, we do end up getting a culture pretty quick on that are sick, then we can take care of it. We've developed a really nice sepsis protocol in the ER, along with recommended empiric therapy for sepsis, to start the antibiotic therapy on patients that meet sepsis criteria. Then when the patients are discharged, I go over and I actually do pull up a chair and I sit down by them because I know all of them. I've been, born and raised in Monroe County. They all know me. They know everything. So, I can't hide. They can't hide. So I just pull up a chair and we sit down and we chat about their medicine. And I'll have them tell me, well, I used to drive to Mobile every day and I had to have something because my foot went to sleep. Well, do you drive to Mobile anymore? Well, no, Cynthia, I'm 97 years old now. And I said, well, let's just talk about not taking this anymore. So, we do try to get them off of their 20 drugs that they're on by the time, hopefully, they go home. And then that helps them. They're not falling down, breaking a hip. There's just so many things that, as pharmacists, we can just take the time to do that. And I have to go mix a chemo in between these, but they've worked with me. The patients know that, like they'll say, pharmacy's taking too long. So I'll see the patient and I'll know them because probably about 70% of them are kin to me. So they'll say, why did you take so long fixing my Herceptin? So then I get into that thing, you want me to do it right now. You don't want me to do it wrong. So you can always smooth it over, and I try to do that. That just kind of gives you what I just told you in a nutshell about MedRec. Antibiotic stewardship. We have a great doc that became a champion with me. He's real young. I like to, he's been out of medical school and completed his residency probably in the last 2 years, and he's also delivering babies there. So every department wants him because he's open to doing all the stuff we ask him to do. So everybody's grabbing him. I know I got to hurry. What have I got? Like 2 seconds left. Antibiotic stewardship. Now, we came up with this, trying to come up with something that's in the computer. I hope I can get with my CPSI, which is our, electronic health records, and come up with, they have this thing that's on the system, but it just goes to a blank screen. So I'm not sure if I have to pay extra money for it. If I do, I probably won't get it. So I got this. And this is something that I do, and my technicians will put it in a spreadsheet, and we'll take it to the Antibiotic Stewardship Committee and discuss it, talk about the money. Yes, everybody gets Rocephin. Unfortunately, it's just like, well, you're admitted you're going to get a Rocephin shot. And so far, like you said, the E. coli's are getting hit hard. They're resistant now, so they're like calling me up. What am I going to give them now? I was like, well, you should have listened to me. Then we also have MedKeeper, which is the pharmacy website, and I have everything on there. Every Joint Commission medication management standard, linked to every policy we have, linked to every protocol, everything that the nurses want or the nurses need or the doctors need, it's on that website. Also, clinical pharmacology is on that website. I post the new antibiograms as they come up. As you see, I don't have this one, I don't think 2018. We just got the data off MedMined, so we'll put together 2018. Takes us a little while. We're slow down there in lower Alabama, but it's the docs really like it and they use it, and we'll compare it in P&T to what's going on with when Felicia gives out the one for the state. We'll compare it and see what our decreases or increases have been. So we've been pretty lucky. We still have some great susceptibilities with a lot of the bugs that we see nationwide and in the state losing some sensitivity, but we deputy dog it and make sure that they're doing what they're supposed to do. And they work with me, the doctor in the ED, he helps me all the time. He'll say, let's change this up a little bit. So we put this together, and this stays in the ED, and it's the sepsis, and it's like the origins, wherever you're susceptible, what your origin of infection empirically could be, and then we give the recommendations based on that. That's what our antibiogram ends up looking like. The yellow ones are the ones that are above 90%. We do urine and non-urine. And then this is what I do at discharge. And the big thing is, because we're trying to decrease readmissions, we're working with, we have a lot of patients, our sickle cell patients. Lord, we have a congestive heart, they're all just all over. But I sit down with them and I get a phone number. And I call them in 48 hours to make sure, because I want to make sure that they got those medicines. The biggest thing I see is when I'm discharging a patient and they look at me and say, I don't even take that when I go home. I said, well, why not? Well, I can't buy it. You think Santa Claus is coming? You know, and it hurts. It makes me, it really makes me feel bad. So we work with patient, try to get them patient assistance, and my technician will dig deep and try to find them something. And we're hoping that eventually, one of my big goals is to start a pharmacy for those patients, because we are a 340B hospital. And, that's one of the things that we've been given a gift from Big Pharma for that. It's non-taxpayer funded. So, we want to utilize it. And I want to start a pharmacy where I can help those patients in retail. Haven't contracted any, just because it's, at this point in our farm, we do specialty pharmacy contracting, but we don't do for the just, non-specialty drugs. So I'm hoping to get that started. I can help these patients out. Insulin, we do give it to them free. If they can't get it, we do have a diabetes education program there, and I'm the manager of that. So if they, just cannot afford their insulin, we will give it to them for free. So they have to complete it. And then we put this in the CPSI so we could document it, that the pharmacy has gone over. Pharmacy technicians, probably the first half of that. Then you'll get into where I come in or the other pharmacist comes in. And we document this in the patient's medical records, where we've gone over and discussed at admission on MedRec and at discharge, and their follow-up call. And thank you very much. Any questions, comments, suggestions? Thank y'all.
Well, let me quickly thank all of our presenters today and the member institutions that you all represent. Thank you again for trying to contribute into the greater good for our state as we try to make improvements here. I'm not going to talk but just a quick minute here, because I know everyone is ready to get out. But I would be remiss if I didn't thank Margaret and Rosemary for continuing to kind of keep us all organized and keep our events going. Okay, you heard several times today the comments about this work is important, what it means for our institutions, and what it can mean for each individual patient we care for. And I think it's there if the real test of everything that we do is, imagine that individual patient laying in a bed as your loved one. And if that's your loved one, how do we want to make sure that their care is delivered in relationship to all the things that we've heard today? I suspect that we want to make sure they get great communications. They want to have a safe environment, do no harm. We also want to make sure that they get to stay home when they go home and don't have to come back with a readmission because we didn't do something perhaps as well as we could have, or perhaps do the training and education for the caregiver, their family member, whomever that might be in that regard. So lots of great opportunities for us, lots of great work going on in your institutions, and we look forward to our next Quality Forum having you be able to help share some of those activities with us, and we'll try to keep you updated with things that we learn in the meantime. So again, safe travels back. Thank you all for being here today.